So, Assalamualaikum and very good morning. My name is Liyana and I will continue our CME with the topic of secondary survey supervised by Dr. Vila. So, what is secondary survey? Secondary survey is a head-to-toe evaluation of trauma patient where we take a complete history taking and do a thorough physical examination where each region of the body is completely examined, and secondary survey does not begin until the primary survey ABCDE is completed and the vital signs of the patient is stable. Okay, so we start with history taking. We
So,
use
Lena,
pneumonic
sorry Lena to interrupt. Okay, just the first question for this slide. So, when they mention that you cannot go to your secondary survey until you complete your primary survey, maksudnya primary survey kita buat sekali je ke?
Kita buat banyak kali, re-evaluate.
Does every patient need the primary survey multiple times, survey dia? Bila primary survey tu kena repeat dia?
Bila kita jumpa something macam,
jawapan je dah ada kat sana.
vital.
We dah buat dah primary survey. What is that? When you noted there is compromise of the vital signs. Masa Amy buat primary survey tu, kalau A dah settle, baru dia boleh pergi ke B. Selagi A tak settle, you tak boleh anjak kepada B atau C. If there's any compromise came back to the B, so you have to repeat back the whole survey again. Bila kita dah complete and your vital stable, your management ongoing, then you go to your secondary survey. Sebab A primary survey tu kan life threatening. Seperti yang Dr. Fairuz kata, you have to settle the problem in first half an hour. Detect and identify, manage, ya? Okay. Continue, ya?
Okay, we start with history taking. We use a mnemonic called ample assessment. A is for allergic. So we ask the patient if the patient have any allergic to medication, mainly antibiotic and also painkillers, so that we doesn't give wrong medication during resuscitation. M for medication. So it can tell us about the underlying medical condition that patient is having. P is for past medical history and P also for pregnancy. So we need to rule out pregnancy in female patient so that we can prevent radiation exposure when we do X-ray. L is for last meal and E for events surrounding the injury. So some injuries can be predicted based on the direction and also amount of energy associated with the mechanism of injury, and the patterns of injury also influenced by the age group and also activities. So we move to the mechanism of injury. We can divide into two categories, either it is blunt or also penetrating trauma. And other type of injuries that is also important include thermal and also hazardous environment. Blunt means without penetration. So it mainly result from a large fall and also motor vehicle accident. And important information to obtain include whether the patient use seat belt, if there is any steering wheel deformation, present or activation of the airbag, direction of impact, either it is frontal, side or rear, the patient position in the vehicle and also ejection from the vehicle.
Okay, sekejap These are the history yang nak kena obtain. Bukan kereta brand apa, bawa dengan bini nombor 1 ke, bini nombor 2 ke. Bukan patient kereta tu tengah U-turn, pusing. Tak. Yang kita nak tahu adalah patient pakai seat belt, langgar steering wheel ke tak, airbag meletup ke tak, langgar depan ke, langgar belakang ke, patient driver ke, passenger ke, tercampak keluar kereta. We're not interested in brand kereta, salah siapa, pasangan mana ke apa. Because sometimes benda yang detail yang korang ambil dalam history ni benda lain. And kadang-kadang these are something that you need to document. Sebab bila I think dia akan balik bila nanti korang jadi MO, kena buat medical report semua, try to avoid to be very exact in detail. Macam kereta patient membawa sebuah Hilux tahun 2021, sebab kadang-kadang patient cakap je tapi later dalam ward tukar statement, so your medical report akan come into question lah. So tapi what you need to understand is what you need to establish ni sebenarnya adalah whether it's a high impact punya injury, high impact punya accident ke low impact. So one way for you to determine whether this is high impact or low impact is by benda-benda macam ni lah. Kereta bengkok ke, kereta total loss ke, patient tercampak keluar daripada kereta ke dan sebagainya. And of course seat belt, airbag ni dia specific sebab sometimes they will have a certain pattern of injury yang you need to look for. Bila patient kata, oh saya pakai seat belt, airbag meletup. Then there are certain type of injury yang kena specifically look for lah in this situation.
Okay. So in this table you can see the mechanism of injury, different type of impact from frontal, side, rear, ejection from vehicle, motor vehicle impact with pedestrian, and also fall from height, and also suspected injury pattern depending on the type of impact lah. Okay. Next. For penetrating trauma, the factors that determine the type and extent of injury and the management includes the body region that was injured, the organ in the path of the penetrating object, and also the velocity of the missile. The most common causes for penetrating trauma is stab wound. Depending on the location, if the location is at anterior chest, we can suspect cardiac tamponade, hemo, pneumo, and also hemopneumothorax. And if the location is at left thoracoabdominal, we suspect diaphragm injury, spleen injury, and also hemopneumothorax. Abdominal visceral injury, and possible if there is any peritoneal penetration. Rarely gunshot lah.
Dekat Malaysia lah rarely Kalau you duduk kat US ke, it's fairly common. So yang tulis buku ni asal daripada US kot. So dia highlight lah. Kalau dalam ATLS apa semua, banyak cerita sikit pasal gunshot wounds apa semua.
For thermal injury can be further divided into thermal, electrical, and also inhalation burns lah. For example, thermal burns, there will be a circumferential scar on the extremity or chest, acute trauma, and the mechanism of burns and means of escape. For electrical burns, we can suspect cardiac arrhythmia, myonecrosis, and also compartment syndrome. Inhalational burns in carbon monoxide poisoning, where there will be upper airway swelling and also pulmonary edema. Next, after history taking, we move to physical examination. Follow head to toe. Head, our face, cervical spine, chest, abdomen, perineum, rectum, vagina, MSK, and also neurological.
Okay, jap, sorry Liyana. Balik pada slide ni. Katalah this guy, trauma, ada tension pneumothorax. Nak buat needle decompression kat mana? Kan Aimi cakap ada dua tempat kan? Dekat mid-clavicular, second intercostal space, or dekat safety triangle. If this guy, laki dalam gambar ni, dia ada tension pneumothorax, awak dah diagnose lah tension pneumothorax. Awak ada satu granula hijau je. Granula lain habis. For some reason, penyelia tengah baru nak cari apa semua. So nak buat needle decompression dekat mana? Kawan-kawan pun boleh menyumbang lah. Ada dua tempat je. So peluang tu 50-50 lah. So ada letak gambar mamat ni kan. So, mamat ni lah specifically.
Awak mamat ni spesifik ni. Mesti ada kan sebab je tengok mamat tu.
So ada gambar ni kan. Semua orang boleh nampakkan gambar ni.
Tengok tu gambar dia.
So this guy sebab mid-clavicular. So kata lampu kat mid-clavicular tak keluar gush of air. So adakah tak ada tension pneumothorax?
Tu safety triangle.
Kenapa safety triangle pula? Why mid-clavicular tidak sesuai untuk mamat ni?
Muscle banyak.
Tengok dia punya pectoralis major dia tu. You know, cup, tak tahulah cup C kot dah ni kan. Tapi maksudnya muscle dia tu punya tebal. So the problem with mid clavicular line ni, mid clavicular second intercostal space anterior ni, if patient macam ni with pack yang besar tu, takut needle awak tak sampai pleura pun. Stuck dalam muscle je. So that's why kalau baca the latest ATLS punya recommendation, sekarang needle compression dia orang recommend buat dekat safety triangle je. Because dekat safety triangle ni biasanya dia in between muscles. Kan safety triangle ni dia in between latissimus dorsi dengan pectoralis major. You go to the space in between. So tak ada muscle besar kat situ. So then the chances of you reaching the pleura is higher lah. Okay, sebab tu saya suruh tengok mamat ni in particular. Nasib baik ada keluar gambar mamat ni kan. So mamat ni buat mid clavicular memang takkan sampailah pleura. Stuck dalam pectoralis major dia je. Okay, tu je dia sebab tiba-tiba nampak gambar mamat ni kan. Terpegun sikit lah. So macam teringat lah. Okay, teruskan.
Okay, so we start with head. So we examine the entire scalp and head for any laceration, contusion, any bruising, depression or any irregularities in the skulls and also vital signs. So we look for any internal head injury, is there any GCF reducing, is the pupil dilated, and also sign and symptom of hypoperfusion and also hypoxia. The eyes should be re-evaluated for the pupillary size, any hemorrhage to the conjunctiva, penetrating injury. If the patient using contact lens should be removed before the edema occurs, and also dislocation of the lens. For maxillofacial structure, we palpate all the bony structures and assess for any occlusion, examine the intraoral and also assessment of the soft tissue. And the maxillofacial trauma that is not associated with airway obstruction or major bleeding should be treated only after the patient is stabilized. And here you can see potential airway obstruction in the fracture of cribriform plate. So we need to be careful lah.
Cribriform plate kat mana? Kalau dalam gambar ni. Oh, ada label dah. Oh, ingat ke tak label tadi? Oh, ada. Nasib baik.
Frequently miss lah for this. Next, we move to cervical spine and neck. So we should presume that all patients with trauma to have a cervical spine injury. So we put cervical collar and then look for any cervical spine tenderness, any subcut emphysema, tracheal deviation, any tenderness at the laryngeal, wound or bruising to the neck, any neck vein distension, any carotid pulsation and presence of hematoma, and listen for a bruit. Next, we move to the chest. Like Dr. said, inspect, palpate, percuss and auscultate. Inspect both anterior and posterior so that we can identify conditions such as open pneumothorax and also flare chest lah. Look also for wound, any bruises, irregular chest rise, distended neck vein in cardiac tamponade and also tension pneumothorax. Okay. Next, we move to abdomen and pelvis. Look for the sign of intra-abdominal injury. Here you can see pelvic fracture sign where there is ecchymosis over the iliac wings, pubis or labia or scrotum. Pain on palpation is an important finding lah in adult patient. At the same time, assess the peripheral pulses so that we can rule out vascular injuries.
Gambar bawah tu, kan gambar yang Splendid Old Navy tu, this is injury sebab apa? Kalau nampak lah benda ni, you suspect apa?
Stabbing.
Yes, ni seat belt lah, typical seat belt. Satu lagi yang across the shoulder lah. Tapi ni mamat ni maksudnya the injury tu is very high impact to the point where dia pakai seat belt, tapi you know injury tu high impact, dia tertolak ke depan lah. The inertia, mungkin dia laju masa tu and hit something very very hard lah. So the inertia tu dia ke depan and the seat belt tu left huge bruise lah dekat bawah ni, seat belt bahagian bawah lah. So this also an indication that it's a high impact punya injury lah. Okay. Of course you need to, bila ada ni nak kena make sure lah patient tak ada bladder injury ke large bowel injury ke dan sebagainya. Tapi this is an indication that it's a high impact injury lah. Patient was going quite fast. Okay. Carry on.
Next, move on to perineum, rectum and vagina. Should be examined for contusion, hematoma, laceration and also urethral bleeding. Rectal examination is done to assess the presence of blood within the bowel lumen, the integrity of the wall and also the quality of the tone, sphincter tone. For vagina examination, we perform in patients that are high risk for vagina injury lah. So detect any presence of blood in the vagina valve and also any laceration. Don't forget to do pregnancy test also.
Remember semua perempuan adalah pregnant until proven otherwise. Perempuan of childbearing age all are pregnant until proven otherwise, regardless of what patient tells you lah. Ini bukan dalam trauma sahaja. Any patient perempuan datang kat ED of childbearing age, they are pregnant until proven otherwise. Okay. Jangan ingat tak kahwin tak pregnant.
Next, for musculoskeletal system, we examine every bone. Any pain, any swelling, any abdominal movement that can help us to identify the location of the fractures. So for adjuncts to the secondary survey includes X-ray of the spine and extremities, CT scan of the brain, chest, abdomen and spine, and also diagnostic procedure like bronchoscopy, esophagoscopy and others. So to minimize missed injury, we should have a high index of suspicion and also do frequent re-evaluation and monitoring of the patient. So this is my reference. Thank you.
Okay. In summary, secondary survey is head to toe examination, finger in every orifice, and detail history lah. This is the time baru nak tanya history. Jangan datang patient trauma datang terus nak tanya history langgar apa semua. Datang primary survey dulu. Make sure that patient will survive. Baru boleh ambil history. Ni kan tengah-tengah ambil history, tiba-tiba patient diam. Sebab korang dah biasa dalam ward kan, the style is history, examination, investigation kan. Tapi dalam konteks trauma, benda tu is out of the window lah. So you need to ensure patient survive first. Baru you boleh ambil history. So that's the main role of primary survey. Sebab tu definition of primary survey is to look for life-threatening cause and to immediately treat it. Maksudnya cari benda yang boleh menyebabkan patient mati. Kalau jumpa, treat dulu. Baru progress lah. Once dah stable, baru go into secondary survey. Okay. So, any question about secondary survey? Ada soalan? Ada soalan nak ditanya kepada kawan-kawan? Kot nak buat quiz ke apa ke? Tak ada. Happy? Everybody happy? Primary, secondary survey sebab this is something yang
daily basis kan we do in ED.
Lah, yang mungkin lain sikit lah daripada kita kata bila dalam ward style punya management kan. So
kita sebenarnya tak boleh tunggu untuk patient beritahu apa yang berlaku pada saya lah. So you all need to concentrate on the mechanism of injury. It's very important for us to suspect the injury yang patient potentially to develop. So kita punya main aim tu kita yang cari apa yang patient tengah alami. It's not we wait until patient tell us.
So primary survey, secondary survey. So konsep primary survey ni can also be applied in non-trauma patient lah. You know, sebenarnya lah kan. Dalam any patient that comes to ED, you can do a quick primary survey walaupun bukan trauma to ensure that the patient survive. Kan macam biasalah patient datang APO tak boleh bernafas sampai-sampai takkan you nak ambil history dulu. So you primary survey dululah, look for the life threatening condition in that patient which is mungkin hypoxia dan sebagainya. The concept kena kadang the principle and concept of primary survey ni primary secondary survey ni is something that can be used all throughout your ED posting lah. Okay, tu je maksud saya. So the ABCD ni is to structure your examination, and then you kena ingat, kalau you perasan all the life threatening cause yang kita mention tadi is usually dah boleh detect dekat A dengan dekat B. That's why you need to do your A, B tu very thoroughly. Because most of the life threatening condition yang kita mention tadi kan, atom FC tu is dekat A dengan B.
Macam mana saya ada add on little bit?
Boleh.
Ya, kalau you akan tengok cara kita approach trauma patient in our trauma zone, it has to be a teamwork. So we want one person to act as a team leader. It will be very chaotic kalau semua orang sentuh patient tu, semua orang nak cari primary survey tu. That will be a bit awkward lah. So one person will be in charge as a team leader. Tugas dia tu yang nak cari tu what is airway, breathing, circulation. So concomitantly the other co-partner dalam team dia akan melakukan sebarang life threatening punya releasing procedure lah. Kalau dia dah detect tu ada terapos, ada tension pneumothorax, okay, then prepare lah needle, appropriate tools untuk reliefkan tension tu. Sama juga kalau dah detect severe hypovolemic shock, there is evidence of ongoing bleeding, massive bleeding, one person will identify the site of bleeding, put the gauze at the side, direct compression. So it has to be a teamwork. Bukan semua orang nak buat primary survey kat sana tu. Okay? So team leader has a very important role.
Kena ada team leader, tapi jangan pula semua orang tak nak jadi team leader. Semua orang nak set line je. Lepas tu tak ada orang yang jadi team leader. Semua orang macam okay, first time sampai terus set line. Okay, aku dah settle lah, aku set line. Lepas tu semua dah tak nak set line. Susah lah.
Kadang-kadang team leader ni boleh juga tertinggal benda sebab dia tengah identify kan, so you at the side pun boleh tolong. Okay, so but the main picture tu team leader has a more responsibility lah. It is a teamwork.
Another moral tu teamwork lah. Everybody needs to know your role,
their part.
If you nampak orang lain dah naik menjadi team leader, you need to support the leader lah. Jangan pula berebut nak jadi leader ke, or berebut menolak role leader ke. Dan the team everybody needs to work in the team, and everybody needs to know their role in the team lah. Tak apa, benda ni comes with practice lah. So try to amalkan this principle lah every time you see even minor trauma pun, because you need to get used to the principle, the concept of primary and secondary survey. Takkan nak tunggu polytrauma baru nak mengamalkan. So with minor trauma pun boleh gunakan prinsip. Boleh. Okay, any other questions kepada Dr. Vila ke, Dr. Liyana ke, atau Dr. Aimi? Mereka bersemangat ni nak present.
Doktor, for needle thoracocentesis dalam tension pneumothorax kan, so kita cucuk branula. Lepas tu branula tu kita biar open, yang belakang tu open ke?
Okay.
Lepas tu macam mana nak tahu bila air tu dah habis?
Nice. Lepas tu
macam mana nak target tu?
Boleh.
Dr. Vila yang jawab ke?
Boleh. Okay, so when your aim nak insert needle thoracocentesis dalam tension pneumothorax kan, Amy? Kan?
Dia punya nak bagi,
it's either tension ke ini ke, your definitive management ni apa? The moment you insert your needle, selepas tu ada lagi prosedur nak buat ke dah habis dah?
Ada lagi chest,
iaitu
bukannya insertion of chest tube.
Yeah, so your definitive next procedure will be chest tube placement. So once you already put your chest tube in situ and it's functioning, you can remove your needle. So branula tu nak connect, tak nak connect, nak buka, tak buka. Okay, aim kita nak keluarkan angin, air kan. So what is point if you go and close it? So either you can connect to a syringe, letak 3-way, okay, you release. Bila patient dah release tension, konsep tension tu maksudnya trachea tadi kan, dia either to left or right to deviated, and vital sign dah compromised, BP dah low, you release the tension dulu. Bila tension dah release, vital sign improve, patient less tachypneic, trachea pun dah central, you bolehlah off temporarily, 3-way tu, tapi jangan buang kita punya branula. It's masih in situ, kita proceed dengan chest tube.
So,
It can be done simultaneously. Seorang releasekan air, seorang insert the chest tube.
the keyword tu nama dia decompression. So you masuk tu you nak decompress je. You want to relieve the pressure build up. And then sementara you buat ni thoracensis tu, kawan you pergilah ambil trolley, chest tube set, underwater seal. The needle thoracensis ni is initial management. You nak decompress supaya patient tak mati. Decompress je lah, bukan nak aim nak relieve semua. Life saving je. So decompress.
Doktor, berapa dalam branula tu kita kena insert?
Sampai dalam pleura. Itu je lah kedalaman dia, sampai dalam pleura. So with tension pneumothorax, bila you buat needle thoracensis tu, you masukkan needle. Once the needle tu dalam pleura, you will hear gush of air because dia ada compressed air dalam thorax tu, air tu akan keluar. Pernah cucuk, bukan belon lah, macam pernah tayar pancit kan, awak cucuk kalau bergaduh dengan ayah ke, dengan adik ke, you cucuk tayar basikal ke, apa semua, dia macam tu lah, decompress kan, ambil pisau cucuk basikal. Kalau bergaduh dengan husband malam ni kan, husband basikal mahal kan, husband basikal mahal kan, cucuk tayar basikal. Awak nampak lah decompression. Lepas tu cakap lah, saya nak tengok decompression ni air keluar macam mana. Dia akan gush of air, dia macam you nak decompress je, nak relieve the pressure build up, bukan nak completely resolve the pneumothorax. Ni you nak relieve the pressure je. Kan macam kalau siapa yang ada pressure cooker kan, lepas tu kan korang sebelum buka tu kan korang kena buang pressure tu kan. Korang kena buka valve tu sikit biar keluar pressure dia. Konsep dia sama, you want to relieve the pressure je. Dan lepas tu buh chest tube. Tu by time. Sebab nak pasang chest tube, kalau awak suruh misi prepare ke, MA ambil trolley ke, awak rasa dalam masa 30 saat tu boleh ready ke? Tak kan? So itulah kisah dia. So it doesn't matter hujung tu nak sambung dengan tubing ke tak sambung, you nak decompress je sebenarnya.
Okay.
It was a good presentation by both of you. Okay. Thank you very much. Thank you, Dr. Fairuz.
Okay, thank you, Dr. Vila. Sorry
Thank you, Dr. Vila.
Okay.
Thank you.
Okay, thanks everyone. Okay, thank you. Bye.